بسم الله الرحمن الرحيم. الحمد لله. اللهم صل على محمد وعلى آله وصحبه وسلم. My name is Muhammad Ibrahim and I'm lecturer at the University of Hargeisa. In this presentation I will talk about the sonographic evaluation of hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis is a thickening of pylorus muscle that connects the stomach to the duodenum. This thickening results in progressive gastric outlet obstruction, which prevents food from passing easily into the duodenum. Pyloric stenosis is relatively common, with an incidence of approximately 2 to 5 per 1,000 births. It is more commonly seen in males. The exact etiology of this condition is not known, but some believe it is acquired condition because it is occurring after birth and most commonly found in infants in the first 3 to 6 weeks. Clinical presentation: symptoms might start as early as 3 weeks, but as it is progressive, the clinical picture usually appears at age 6 to 12 weeks. Clinical presentation of hypertrophic pyloric stenosis consists of one or more of the following: non-bilious vomiting described as projectile, very hungry baby with weight loss, and eventually malnutrition. In some cases, palpable olive-sized mass in the epigastrium or right upper quadrant might be seen. Visualization of exaggerated gastric peristalsis through the abdominal wall. Ultrasound is the imaging method of choice. It has been found to have a sensitivity and specificity close to 100%. It can show the anatomy and function of the pylorus, and it has no ionizing radiation. Patient preparation: initially, baby should be on fasting for 4 hours. This avoids gastric gas obscuring the view of pylorus. Then water is given to the baby or breastfed, and this will give very good acoustic window to the pylorus. Scanning techniques: place the transducer transversely across the right upper quadrant, just below the xiphoid process. Find the gallbladder, then turn the probe obliquely sagittal to the body. In this way, you will see true longitudinal plane of the pylorus. Freeze the image and measure the length of the pyloric muscle. In this image, you see the antral with gas in it, anterior hypoechoic muscle, then the canal, and below the canal is the posterior muscle appear as hypoechoic homogeneous texture. The length of the muscle is measured from the proximal to the distal extremes of echogenic central canal. Another image is here. Here is the antral filled with fluid. Muscle is hypoechoic here, and here is the canal appears as an echogenic strip. This is how we measure the muscle. The length is measured from this point to this, and thickness is measured from here to here in a single muscle layer. For transverse view, find the gallbladder and then angle probe medially until the pyloric muscle is identified. It will appear like a target sign. Thickness of the muscle can be also measured in a transverse for a single muscle. Put the cursor at the upper layer of the muscle to the central echogenic line, which represents the canal. To diagnose it as hypertrophic pyloric stenosis, the length of the pyloric muscle should be more than 14 millimeters, and thickness should be more than 3 millimeters. This is an example of hypertrophic muscle. The muscle is hypoechoic and central mucosa is hyperechogenic or hyperechoic. When we measure the muscle, its length is 23 millimeters and thickness is 6 millimeters. Here's the antral containing fluid. Another example of hypertrophic pyloric stenosis: the muscle is elongated, measuring about 21 millimeters, and thickened, measuring about 6 millimeters. And here is the antral containing fluid. The transverse image shows the target sign. It's a donut-like appearance, hypoechoic in the outer circle representing the muscle, and echogenic in the inner, representing the canal or the mucosa. Okay, let us see here 3 signs that are associated with the ultrasound pictures of hypertrophic pyloric stenosis. Number 1, antral nipple sign. Antral nipple sign is this protruding nipple-like that projecting into the gastric antral. It is actually redundant pyloric mucosa protruding into the gastric antral. The second sign is cervix sign. Those who are familiar with the pregnant cervix, they will find that the indentation of the pylorus into the fluid antrum looks like pregnant cervix. Here is the pregnant cervix with fetal head here, amniotic fluid here, and cervix. Look how they look like each other. Transverse view of hypertrophic pyloric muscle will give the appearance of target sign. This consists of hypoechoic muscle surrounding the echogenic mucosa. Pitfalls. Sometimes you might see contraction of the terminal region of the antrum, which mimics pylorus, and show false elongation of the pyloric muscle. Like in this case, you see what looks like pyloric muscle. When you look it carefully, you notice that there is peristaltic contraction followed by antral relaxation. Here is another example of antral contraction. See here, fluid is passing area of pylorus, contraction, then relaxation. Finally, 2 comments are to be stated here. If there is gas in the pyloric area, incline the patient with the right side down. This will move the fluid to the interested area and gas will go up to the antral. The other comment is hypertrophic pyloric stenosis is a progressive lesion. If initially scan shows borderline or negative but clinical symptoms persist, patient should be rescanned 2 weeks later. Thanks for watching.